So the ability of heart function is decreased in congestive heart failure. So then we also learned that ejection fraction, the amount of blood ejected after each contraction is known as ejection fraction. And echo, we told we can also do it by MRI nuclear study, huh? But a simple one is echocardiogram, very cheap. I don't know what's the price here. In India, it will be something around 500 to 1000 rupees. Very easy. You can also get the information from MRI. So this is then we told the ability of heart function is decreased. So distant organs will not get oxygenated blood. Then the compensatory mechanism, heart enlargement, blood volume accumulation, all this will happen. Renin-angiotensin will activate. Body want to do good, but it will activate and worsen the disease. We studied all these things. Then we also studied sympathetic nervous system activation. That's a little good. Then we have seen causes and symptoms. Then classification of drugs we have discussed. Then we discussed about cardiac glycoside exclusively. Exclusively cardiac glycoside, the chemistry, the test for this aglycone, glycone portion. Aglycone or genin is aglycone or genin is the one which is responsible for pharmacological activity. Then glycone, the sugar portion, is responsible for carrying the drug from the site of to the site of action. So the sugars will be 3 to 4. The linkage also we studied. Please try to recollect. Please try to concentrate. Please. So this will help in carrying the drug to the site of action. Then we told 2 drugs from the natural, that is Distalis lanata, Distalis purpurea. Purpurea means purple color like. 1 second, please. So positive inotropic drugs. So in the compensatory mechanism, we learned that our body will activate, what's that? Adrenergic nervous system. In the same concept, these drugs, positive inotropic drugs, like dobutamine, dopamine, are used in heart failure for emergency conditions. And also you can see it here, the benefits are for short period of time. They cannot be used for long term. The ejection fraction decreased completely, then you are in trouble, then we can use these drugs. Dopamine, dobutamine. You can use slowly by IV route of administration. What happens? No, they are positive inotropic drugs. They increase cardiac output. Then what happens is that excites beta adrenoreceptor, so which dilates vascular and decreases after load. So these are the drugs. Example is dobutamine we have kept here. This drug only for short period and emergency time we use these drugs. Then one more class of drugs, phosphodiesterase-3 inhibitors. Phosphodiesterase-3 inhibitor. All these drugs are the examples. If you see the classification, so these are positive inotropic drugs. Cardiac glycoside, beta adrenergic agonist, and phosphodiesterase-3 inhibitors. So now here, what these drugs, you can see it. These are, we call them as non-glycosidic They're not glycosides, as well as non-sympathomimetic inotropic agents. And they are bipyridine inotropic agent. So there are two pyridine molecules here. You see, this is one pyridine molecule, this is one more pyridine molecule. So two pyridine molecules are present. So that's why we also call it as bipyridine inotropic drugs. Examples of these drugs are amirinone, milrinone. Now, among vesininone, these are the three drugs available under phosphodiesterase-3 inhibitors. Among these three, this milrinone is widely used and more potent. Here also, these drugs also for short term, more potent, safe drugs and short duration of action. Now, they are also used for short-term management. Short-term management of CHF, congestive. CHF means we know, no, congestive heart failure patient who do not respond adequately to digitalis, digoxin, diuretics, and vasodilators. So this is amirinone. Amirinone has bipyridine nucleus. Now here you can see it, there is amino group here, amirinone, whereas in milrinone, it has a cyanide group. This cyanide group is responsible for more vasodilation and more potent drug. Compared to this amirinone. Milrinone is very, very good drug. It has found to have 30 times more potent than amrinone. Amrinone. So this is about phosphodiesterase inhibitors. Now, how these drugs inhibit? Phosphodiesterase inhibitors are the drugs if they inhibit. Let us see. First, we know that ATP is produced. ATP will convert to active form. ATP is also energy by the help of enzyme adenyl cyclase. By the help of adenyl cyclase, it becomes cyclic AMP. Now, this is active form. Now, what happens is that cyclic AMP, if it is continuously active, what happens? Body cannot be tolerated. So, God has created, there is one enzyme called as phosphodiesterase. What's the name of enzyme? Phosphodiesterase. Now, this diesterase, there is here between phosphate group, there will be ester group. That ester group will be broken by phosphodiesterase. During this process, the cyclic structure which is present here, you see, we have to write the small c. This c has to be small, remaining everything capital letters. Now, the cyclic AMP will convert to adenosine monophosphate. This is inactive. Now, our drugs, this milrinone, amirinone, what it does is that it blocks this phosphodiesterase, thus preventing cyclic AMP, conversion of cyclic AMP to AMP. So when it blocks this process, the levels of cyclic AMP increased. So this cyclic AMP, what it does, mediates phosphorylation of protein kinase and which activates calcium channels. It's the same mechanism. What is for sildenafil citrate, Viagra tablet? The same mechanism, but it acts on the blood vessels which are present on the penis. So this is different. These drugs are blocking at the cardiac muscle and the blood vessels. So what happens is that the force of contraction increases in the heart as well as in the blood vessels. It causes vasodilation. So two effects we can get this with the help of this drug and with the help of this drug. So please try to remember ATP is converted to cyclic AMP with the help of enzyme adenyl cyclase. Now cyclic AMP is an active form which is converted to inactive form called as AMP. The cyclic portion will be gone. Then it is called as AMP. What is the enzyme responsible for this? Phosphodiesterase. Now, our drugs will block this and increase the cyclic AMP. Rest is, The cyclic AMP will help in phosphorylation of protein kinase C, secondary messenger, which also in turn release some more secondary messenger calcium. So if this is occurring in the heart, it increases contraction of heart. If it is occurring on the blood vessel, it causes vasodilation. So positive inotropic and vasodilation effect it causes. So these are the effects which you can learn. Now, let us go to next slide. Diuretics. Diuretics, very, very important drug. Again, I'm telling that these drugs, patient will be given 3 to 4 drugs, digoxin, or any diuretic, or AC inhibitors, or beta blockers they give. They don't give one drug. So among the diuretics, widely prescribed drugs in congestive heart failure is you can prescribe thiazides, which are of low grade. See, these are of low grade. That means they produce diuretic effect little. They produce diuretic effect little. That is thiazides. One of the best drug is hydrochlorothiazide. Hydrochlorothiazide. And one more low grade drug is anti-aldosterone drug, which is also called as potassium sparing diuretics. Potassium sparing diuretic. One of the best drug is spironolactone. Spironolactone. We have seen digitalis produces potassium loss. Hypokalemia is one of the side effect. So to avoid that, so I was telling in last class, so the levels of sodium and potassium has to be monitored for this patient. So when potassium levels goes down, we know that because we are giving these drugs, the side effect is hypokalemia. So they specifically use this spironolactone. Specifically, they use spironolactone. Some more high grade, suppose if the edema is more, if the edema is excess in the body, then what happens? You can give a strong diuretic. Strong diuretic, that is loop diuretics. Loop diuretics. Example is furosemide, torsemide, itacrinic acid, and butanide. Any drug. What is the advantage? This is strong, they tell, but this is given in the form of injection. Whereas this drug, torsemide, is oral drug and it is long acting drug. Torsemide is a long acting drug. So 1 tablet per day. And also the timing is very important. And if you administer this drug in the evening, what happened? Patient needs to go to washroom in the night frequently. So you should ask the patient to take in the morning. If the patient takes this tablet in the morning, something around 9 something, so the effect will decrease. 1 dose we take, the effect will decrease by the end of the evening. Then in the evening, we can start this spironolactone. In the evening, they start with a spironolactone. So this is the way how the drugs are administered, are prescribed for the patient. Any drug, they can also give ethacrinic acid or butanide, any drug, and how they act. I was telling many times that water and sodium are best friends. If you take sodium more, water will start accumulating in our body. So here, most of our drugs will block, these diuretics will block sodium reabsorption. So consider this is a, what is that? Uh, one loop of Henle or nephron. What happens is that in the urine, this is the lumen of our nephron. The sodium, whatever is present, is reabsorbed into the body. The sodium is reabsorbed. This is our blood vessel, you consider. This is also our nephron. Now, what happens is that our drugs blocks this. So what happens? The sodium levels in the nephron will increase and goes out. So when sodium is decreased, automatically blood volume also decreases. So reduced blood volume, so reduced venous pressure and cardiac preload, and this causes edema. So this causes reduction in the edema. So these are the how these drugs compulsory these drugs are prescribed compulsory. So two drugs depending upon the condition to condition. So let us see next. This is the one of the drug we kept here, Torsemide, which is given for multi-purpose. It can be given in heart failure, liver diseases. In the liver diseases also, what happens? Fluid starts accumulating in the abdomen. Ascites, we call it as. So even in that condition, fluid should go out. So in that condition, we can use, even in the kidney diseases, we can give. This is the Torsemide, which is a high ceiling drugs, very strong drug and long duration. So this is the drug. So these drugs have, you see, sulfonamide group. It has sulfonamide group and also has an urea derivative. You consider this as urea if you consider this sulfonamide group. And the structure has pyridine nucleus in it. Pyridine nucleus. So where does these drugs act? This all furosemide, this ethacrinic acid, they act at the loop of Henle. Loop of Henle. So this is the about Torsemide. Very good drug, and it's a long-acting drug. I told you what is difference between when you have to select. Furosemide is also very good drug, but it is given in hospital setup. You can see it compared with other loop diuretics. Torsemide has prolonged diuretic effect than equipotent dose of furosemide. Furosemide. And one more advantage you can see, relatively decreased potassium loss. Decreased potassium loss. So even the drugs, please, thiazides, these drugs, thiazides also have loss of potassium. These thiazide drugs also loss. All the diuretics will have loss of potassium, except this aldosterone blockers. So anti-aldosterone potassium sparing diuretics, except this. This is very cheap drug, spironolactone. Except this, remaining all diuretics produce loss. Even our digitalis is also producing loss. I'm emphasizing more and more. Why? Because the potassium is very, very important here, especially this. When it goes down, patient may go to coma and also death. So that's what we are emphasizing. This spironolactone is very, very important drug in the prescription. So this is now. AC inhibitors also we can use. AC inhibitors we can use because it decreases renin-angiotensin mechanism. We have seen the compensatory mechanisms, no? Compensatory mechanism. What happens? Renin is increased, increased angiotensin 2, blood volume is increased. So here we can use ACE inhibitors. ACE inhibitors, which plays very important role, very, very important role. Any drug you can prescribe. Suppose if AC inhibitors, the side effect we have studied, dry cough. Already patient will be having cough because, what's that? Because of fluid accumulation in the lungs. Fluid accumulation in the lungs. So when fluid starts accumulation here, when you tend to get cough. So to avoid that, we can use these drugs. When you get a cough, don't use these drugs. Sorry, you should not use. Go for ARBs. ARBs you can go. One of the best drug among AC inhibitors for this purpose is perindropril. Perindropril. It is usually given with any of the diuretics. Perindropril plus hydrochlorothiazide, enalapril plus hydrochlorothiazide, any depending upon drug available, doctor will prescribe and can be prescribed. You can see it here in this diagram. You see perindropril, amlodipine is also present. Combination is also very, very available. Now here for our concern, you see perindropril, one more diuretic, that is indapamide. Indapamide. These are also very good drug. This drug is also very drug. The main use of diuretics is to excrete urine to increase outflow of urine. When urine outflow is increased, what happens? Fluid accumulation will be stopped. So patient, even when patient will be very comfortable when he sits like this. But once he starts lying down, he will be having difficulty in breathing and all those things. And so patient needs to sleep like this. What's that? Bed or pillow. More pillow he has to put support so that patient will be more comfortable. When he starts lying down, vomiting and all the not vomiting, cough, difficulty in breathing will come. Now coming to perindropril, we have seen it is a dicarboxylate containing drug. Now this is the we have seen SAR. You please refer to that beta antihypertensive drugs. All those SAR we have studied. Now this is the this is the heterocyclic ring which is present, that is octahydro. There are 8. So hydrogens are present. Hydro, indolin, indole. This is indole group. If it was ring and here it is a indole molecule. Indole molecule. Now it has been saturated. That's why we written hydro. Hydro. Carboxylic acid group is present. Now this is the ester group. The captopril. All these drugs are prodrugs except captopril and lisinopril we studied. Now this on body, what happens? This esterases, it goes and we get perindropylate. which is the active molecule. Yes, please.
Excuse me, sir. I remember you said that the calcium channel blockers are contraindicated in CHF. How
Yes,
come these peridopril idapamide is combined with amlodipine and it's a CCB?
yeah. Very good question. But what happens is that perindopril plus amlodipine is very good drug for hypertension. That combination, and also in new suggestions are telling that in congestive heart failure, if you are associated with hypertension, hypertension, then they are prescribing very low dose. When I was seeing today, I also found calcium channel blockers, patient with high blood pressure plus CHF, plus CHF, then they can use. But this combination is very good drug for blood pressure, high blood pressure. Not here. Sorry, I kept here wrong. Yeah. But there is new rules. Every time these rules are changing. If the patient is suffering from high hypertension plus CHF, they are prescribing. They are prescribing. Usually we should not prescribe. But what to do? Hypertension very high, then you should. Okay. Now, beta blockers. Among the beta blockers, valsartan is widely used drug. Valsartan is widely used drug. This is valsartan. Now here, it's a beta blocker. Here you see tetrazole structure is present, and one more carboxylic group is present. Valsartan is very good drug, is used for congestive heart failure. Especially this valsartan is combined with nowadays, no, it is combined with this is new combination of drug, Sacubitril. I will discuss about that in coming slide. Next slide. Valsartan plus Sacubitril is the first combination, first agent to be approved in new class of drugs called as angiotensin receptor and neprilysin inhibitor. Neprilysin is an enzyme. We are blocking that. So this combination is very good drug. They are prescribing more for congestive heart failure patients. Sacubitril plus valsartan. So this is, so let us discuss about this valsartan, Sacubitril. Valsartan we have already discussed. Please refer to that antihypertensive drugs. Among all those beta blockers, valsartan is widely prescribed for CHF. Now here, Sacubitril. We want to discuss about Sacubitril. Before discussing about Sacubitril, please try to, we will learn about one of the peptide. One of the peptide called as natriuretic peptide. Natriuretic peptides. So this is the new concept. Please try to observe. So what is the function of natriuretic? As the name indicates, these drugs, these peptides will help in excretion of sodium. Which is very good for us. So it helps in excretion of sodium. So what happens is that when heart failure occurred in our body, suppose if heart failure occurred in our body will produce two peptides. What are those peptides? Natriuretic peptides. What is the function of natriuretic peptide? Will increase in excretion of sodium. When sodium goes out, it also takes its best friend water out. So edema decreases. So that's an advantage here. So when congestive heart failure is happening, then body will produce these two peptides, that is natriuretic peptides. That is atrial natriuretic peptide, which is called as ANP, and brain natriuretic peptide. Brain. One is in the atria, one is in the brain. So these peptides are released. These peptides are released. Now let us see what it does. So natriuretic peptide, as we learned now, will help in excretion of sodium. So what happens is that it also has vasodilation effect. So blood pressure is decreased. Then one more thing is that it increases glomerular filtration rate. That means circulation is improved. Congestion is stopped. So what happens is that in the kidney, excretion of urine occurs. At the same time, it also decreases renin. It also decreases renin. So when it decreases renin, what happens? Angiotensin 1, angiotensin 2, you all know, aldosterone, all these decreases. So in all these, what happens? The blood volume decreases. So these are the natriuretic peptide function. But what happens is that these ANPs and BNP is getting inactivated by the help of enzyme neprilysin. These should be very good, but what happens? ANP, BNP are getting immediately. They are getting once as soon as they release this neprilysin enzyme is released, and neprilysin will inactivate this ANP and BNP. Now we are giving they found the drugs that is Sacubitril, which is a new drug. There is a lot of research going on this neprilysin enzyme. They're also seeing that this neprilysin is also responsible for Alzheimer's disease. Lot of research. Maybe in the next 5 to 10 years, we may get one more neprilysin inhibitor used in Alzheimer's disease. Alzheimer's disease. Clear, please? Any doubt here? Yes, Priska.
I don't understand the second image here down. Do you mind going back to it?
You don't mind?
I'm saying I don't understand this second image. If you can explain it again.
No, what I'm telling is that, yeah, the same concept. You see, in the heart, what happens is that when congestive heart failure occur, natriuretic peptide levels are increased. This is clear?
Yes.
Now, what happens? This natriuretic peptide is getting inactivated by neprilysin. Neprilysin is an enzyme. So generally enzymes, we have ASE, but it doesn't have. See, now neprilysin is getting inactive ones. Inactive ones. So if you block, their levels are increased. So improvement of CHF. The same concept in Alzheimer's disease also. In Alzheimer's disease also, you see, brain beta amyloid peptides is you get this. That's what we told. Brain natriuretic peptide. Then this BNP here, you consider this is BNP. BNP, what happens is that BNP is getting degraded. What is the enzyme? Same neprilysin. So when it degrades, what happens is that amyloid is depositing in the brain and causes Alzheimer's. They're trying. So they found that neprilysin inhibitors will have better in Alzheimer's disease, but still it is in the research. It is in the researcher. So this is the one more thing. That's why we are telling ANP, BNP. Even in future, you may get neprilysin inhibitors, which are promising in treatment of Alzheimer's. The same concept I'm telling. And one more thing is that, you see, neprilysin, along with this, it also blocks the activity. It blocks the activity of ANP and BNP. It also inactivates bradykinin, endothelin, and glucagon-like peptides. So even in diabetes, there is some chances they're telling they can get some drugs. Maybe in future, they're trying. So here, this bradykinin is also getting inhibited. Is also getting inactivated by this neprilysin. Now, next, let us see how this drug acts. How this drug acts. Now, Sacubitril is a prodrug. Sacubitril is a prodrug. You can see it. This is a diphenyl group, 4-oxobutanoic acid. See, 1, 2, 3, 4. 1, 2, 3, 4. 4-oxobutanoic acid, totally butanoic acid, then diphenyl group. Now, what happens is that this ethyl group is present, you see, as an ester bond. As an ester bond by esterases. By the help of enzyme esterases, what happens? This will go out, ethyl will go, and you will get sacubitrate. You get this sacubitrilate. The drug is sacubitril. Now, the active form is that when you get same like enalapril, enalapril is a drug. Active form is enalaprillate. Here also sacubitrilate. So how it happens? By the help of enzyme esterases. By the help of enzyme ester group, no, it gets removed and it is active. Now this sacubitril will inhibit the enzyme neprilysin. It will inhibit the activity of neprilysin. When it inhibits neprilysin, what happens? The levels of ANP and BNP are increased. You see, ANP and BNP are increased. When ANP and BNP are nothing but natriuretic peptides, so it causes excretion of sodium. So that's why we are nowadays, I used to emphasize sodium is the culprit for all the cardiovascular diseases. So reduce salt intake. You can also suggest your parents that salt should be reduced. Salt should be reduced. So you can see how many drugs, all the diuretics are decreasing the sodium. All our AC inhibitors are decreasing the sodium absorption. So try be a smart kids, children, students, and control your diet. If you want to survive for a long period, be a smart boys and smart girls. So this is it. So this is how this drug acts. Sacubitril is a prodrug. So by esterases, you get, what's the drug what is the active form? Sacubitril later. So this is the mechanism of action. I told you in the previous slide that it is usually combined with valsartan. Now you can get the information about the name. See, valsartan is angiotensin receptor blocker, and neprilysin is also sacubitril is neprilysin inhibitor. That's why it is called as angiotensin receptor neprilysin inhibitor, ARNI. Angiotensin receptor neprilysin, N for neprilysin, I for inhibitor. So this is about sacubitril. Now you see, this is the combination, how it helps. So this is very good combination. See, sacubitril plus valsartan. You see, sacubitril is blocking neprilysin. It increases the natriuretic peptide. Valsartan will also decrease angiotensin 2. If you can remember here, you see, these two are decreasing the renin levels. These two. If this getting inactivated in the compensatory, if these two gets inactivated, what happens to this level? The level of renin is increased if this is blocking. So that is the reason why this valsartan is combined. But when they done trials, they have done with all the beta, ARBs. But these two combination improved activity, improved patient compliance. So they have marketing in the combination. You can see it here. Blood pressure is decreased because of all this. Water and sodium retention is decreased. Overactivation of sympathetic nervous system and ventricular remodeling occurs. And this is the best combination. You can see it. You can click on this or copy this. You can read about the article which is responsible for all this. More information you can get. So you can see it here, sacubitril valsartan in patients with atrial hypertension results in marked reduction of blood pressure. So this is advantage. Now, beta blockers. So this is a little contradictory like it is. So we can go to classification of drugs. So please try to concentrate. See, here we told agonist also will help. Again, we are telling beta blockers. Again, we are telling about the beta blockers. But there was a research done, and nowadays they are also prescribing. Just like calcium channel blockers. I told you, generally they are contraindicated. But new research, maybe in future. So here you can see it. What was the reasons and all those given for beta blockers. So we're almost finishing. So please listen. This is a very important slide which we discuss in the beta blockers activity in congestive heart failure. So here you can see what happens in heart failure. What see here, please. In heart failure, there is cardiac output decrease. Up to here we know. It's a promising symptom. Cardiac output, ejection fraction is decreased. Nothing but cardiac output. Now, in response to this, adrenergic activity is increased. Even we studied in compensatory mechanism, same one. So here adrenergic activity increased. What happens? Activation of cardiac adrenergic activity is increased. So when it increases sympathetic nervous system, activation of cardiac beta 1 receptor happens. This in turn increase heart rate and contractility. If this is happening, if it is normal, it's okay. But sometimes the patient will get arrhythmias. When heart rate increase, their heart rate also will decrease. So when heart rate and contractility is increased, the patient may go to arrhythmias, irregular, and he may die. See, aggravation of the disease and sudden arrhythmias they have observed. They have observed. So when heart rate, please sir, before coming here, you can see it. See here, adrenergic activity increase, activation of cardiac receptors, that is beta 1, increase heart rate, contractility. Then it also increased cardiac output. That's good. It also increased cardiac output. But what happens for some of the people, they have observed that it is becoming aggravation of disease and sudden cardiac death is observed. So after studying all this, they started using beta blockers. So when beta blockers, if you give, what happens? It inhibits this process, and also prevent sudden arrhythmic death. So this is the reason they are prescribing beta blockers. The most prominent beta blockers which they are prescribing is Metoprolol, Carvedilol, and Bisoprolol. These are the three drugs which are prescribed. Again, among all this, Carvedilol is the best. Drug. So let us see what it does. You see, beta blockers have been shown to reduce morbidity. This is a systematic study. It reduced morbidity, mortality of the patients with mild, moderate, severe heart failure. So that's the reason there was many publications. So we nowadays I included in this. So you can see the impressive survival data collected from several large randomized trials have in recent years made beta blockers a component of standard heart failure therapy. Clear? This is an explanation. Any doubt, please? Andrian. Andrian,
No doubt, sir.
can you give some of the drugs? I'll ask some questions so that I can know that you people are following or not. Anisa. Anisa?
Yes.
Okay. Anisa, how is Sacubitril is acting?
It is you first for it to become active. You have
Little
to
bit
achieve
louder, please. We are not at all able to hear you.
Can you hear me now?
No, maybe your laptop voice or something you can increase.
And now?
Yeah, it's clear. Good.
Okay.
Appreciate you.
To activate the sacubitril, you have to get rid of the ester group by using the enzyme esterase, and it becomes a prodrug which is activated to sacubitril.
Okay, that's good. What is its mechanism of action? Super, good. You're following. What is its mechanism of action?
The mechanism of action is, and when heart failure occurs, there is this peptide known as natriuretic peptide, which is produced. Now, this natriuretic peptide induces the excretion of sodium, and when sodium is excreted, water follows it, thus reducing edema or the tension on the heart. Thus, it reduces the overload of the heart. Is that?
Yeah, what is the enzyme? Super. What is the enzyme it is blocking?
The enzyme it blocks. I don't think I remember that.
Neprilysin.
Yeah, neprilysin. They're the one that is responsible for Alzheimer's disease.
Yeah.
Somehow, yeah.
So, very good. Perfectly following. Then, Disha.
Yes.
What is the best combination for sacubitril?
Sacubitril and valsartan.
How does valsartan help here?
It's an angiotensin. They're both angiotensin receptor neprilysin inhibitor.
Okay. What about the acidic functional group present in this ARB for valsartan?
The methyl butanoic acid.
And
I don't know the other one.
okay, good, very good. Next, yes, tetrazole. We have seen no tetrazole and carboxylic group. Where is it? Why it's not one? Yeah, there. Carboxylic group and tetrazoles are the acidic functional group present in valsartan. Now, can someone tell about let me ask, Elizabeth. Elizabeth. She is not in meeting. Okay. Emmanuel Chesa. Emmanuel, please unmute. Isaac. I'll give option for you all who are not responding.
Yes.
Emmanuel, can you give some of the drugs, AC inhibitors prescribed here? Hi. Hello, gentlemen, please. Isaac. Okay. Karishma.
Yes, sir.
Give some of the AC inhibitors used in this.
We have the pril, so captopril, enalapril, perindropil.
What is the effect of these drugs on potassium levels? Same, Karishma, for you only. Are you able to hear my voice?
Yes, yes.
Yeah, please.
I think not sure.
Who can tell? Whom to ask?
I think they increase the potassium levels.
They increase or they produce hypokalemia?
They produce hypokalemia.
Then what are the drugs to prescribe when there is loss of potassium? How to prevent? Potassium sparing diuretics, spironolactone. That is very, very, very important drug. I explained here. Spironolactone should be given. All the thiazides, I told you that. Please remember, my students. All the diuretics produce potassium loss. Potassium loss, except potassium sparing diuretics. That is spironolactone. How does it act? It blocks aldosterone levels. Aldosterone levels. Aldosterone, please remember, please everyone should listen to this. It's a very important in examination point of view or your pharmacology. Consider. See here, what is the use of, how does this spironolactone act? It is anti-aldosterone. Anti-aldosterone. Aldosterone, we also learned in renin-angiotensin aldosterone mechanism. Aldosterone will act at the last collecting ducts of nephron. Here what happens is that body, our body will reabsorb sodium. And it sends potassium to the urine. This is urine. This is our blood vessel, you consider. Other side is the blood vessel. This is in the urine. In the urine, whatever sodium is present, with the help of aldosterone, what happens is that sodium is reabsorbed. And potassium loss occurs. Now, when you block this aldosterone, what happens is that potassium will be in the blood itself. That's why they are called as potassium sparing diuretics. One of the cheapest drug, but it has side effects. It is a steroidal drug. For men, it causes breast development, gynecomastia. So some of the problems with that. Hormonal disturbances for women also it occurs. Side effects are there. So one of the best drug, I told you people are listening, please listen, try to listen. So this is an, now let us see. Almost finished. Very good for responding, especially what is that? Anissa, super sheet. She has told the answers. Now this is what we studied about beta blockers. Beta blockers in the trials, in the clinical trials, they found that they have very good effect on congestive heart failure patients. So,
Excuse me, sir.
yes, Macharya.
Before you go on so far, both the potassium sparing diuretics, the one that we are saying are antagonizing aldosterone. Can you give us an example of one drug, please?
That's what I told, no, spironolactone. Here I written,
Okay.
Here,
Spironolactone.
I'll 1 second, I'll show you. Sorry. Here I showed you just now. Spironolactone. We'll study diuretics also. Spironolactone, better drugs are also available, but when you consider the price, and also congestive heart failure is almost, if you get this bye stage, what's up stage, like, so sorry to tell, so patient he may die. So gynecomastia, those are not the problems. So, and the price of this is very, very less. Yes. Patoki. Yes, please.
Yes, you also said torsemide decreases potassium loss. So can it also be classified as spironolactone?
Can you repeat, please?
I'm saying you said that torsemide, it decreases potassium loss. So can it also be said that it's a spironolactone?
Yeah, definitely. Furosemide, I given one statement, all the diuretics will produce potassium loss. So you can give this drug, furosemide, torsemide in the morning and give the spironolactone in the evening. So in the morning, what happens? Patient go to urine, so edema is reduced. When you take in the evening this spironolactone, from there onwards, it stops again, potassium loss. But one more important thing is that it is a weak drug, weak diuretic. Again here, it also produces urine excretion. And also it protect potassium loss. That's the advantage of this spironolactone. Yes, Fitoki, did I tell the answer for you?
Okay, no, you've not really answered what I'm asking. What I'm asking is that you said that torsemide decreases potassium loss. So is it also a spironolactone?
No.
Different.
Which I'm thinking you here in this slide, I think you are considering this slide. In this slide, here we are comparing torsemide with that of furosemide. Here, when you compare this, nowadays, no, furosemide is also good drug. Here is it. This is a furosemide. In this slide, we are comparing these two drugs. And we are telling that torsemide is prolonged diuretic drug and decreased potassium loss. This torsemide also produce potassium loss. But when you compare between these two drugs, this produce less potassium loss. There is also a hypokalemia even with this torsemide, even with furosemide. But what is the statement is that, please make clearer, the torsemide potassium loss is little less. Little less. That's why nowadays, instead of furosemide, torsemide is taking into the market. In the market, they are prescribing this drug. Torsemide is widely prescribed. That is the statement. Don't get confused here. You can see it here. Here, the mechanism of action is, this is sodium potassium 2 chloride symporter. You consider again, consider the, sorry, let me clear all this. So please, you consider this is a lumen. This is lumen, or lumen of nephron. Now what happens at the loop of Henle? Loop of Henle means there will be twist in the Bowman in the nephron. Here what happens is that you see all the sodium, potassium and chloride are reabsorbed. So you can consider here sodium, potassium and chloride are reabsorbed. And we are telling symporter. Symporter means all the ions will move in one direction. This is, I told you that urine, that is a nephron. This is blood vessel. This is blood vessel. So all these are coming. If you block here, what happens? All will be present in the urine and goes out. But compared to that furosemide, torsemide is little loss, not completely lost. This is it clear now?
Yes, thank you.
Yeah, very good for communicating. Now we are almost finished. Please. This is the drugs which we were telling. Metoprolol. Metoprolol. Sorry, I am every time telling Metoprolol. This is one of the drug. Generally, as a pharmacist, you people should remember that whenever there is salt form, see for example here metoprolol tartrate is present, tartrate, tartaric acid, it is made with the salt, tartrate. One is succinate. Succinate. The drug is available in two salts, tartrate and succinate. So they are not the same. Generally, you see, if there is any penicillin hydrochloride or penicillin sulfate, you can interchange if it is available. Now, in metoprolol, tartrate and succinate, you should not interchange. Because succinate, if the drug is available in succinate, it is a long-acting drug. Long-acting drug. Suppose if doctor prescribes metoprolol succinate, you only dispense metoprolol succinate. If doctor prescribes tartrate, metoprolol tartrate, you only dispense that. Don't interchange. Generally, we can interchange. This is the special case. Why? Because succinate is a long-acting drug. It can be as a, what is that? What is that? Controlled release dosage form. Whereas tartrate is a immediate release. Immediate release. Immediately the drug is released and it shows action. Suppose if the blood pressure is high, immediately you want to show action, you should give tartrate. If you want to maintain the blood pressure, then you can for 1 day, 24 hours, then this doctor will prescribe metoprolol succinate. You can remember, you see, like this, succinate. Yes, single dose. Single dose per day. Tartrate, T, 2 doses per day. 2 doses per day. Is it clear, please? Listening, no?
Yes.
No. So this is very important. So generally, as a pharmacist, in future, if there is one salt, another salt, we think the drug is same, it is only salt, but this is different here. You can also check in internet. I'll post you in the WhatsApp, our group. You can learn more. So this is about tartrate, metoprolol tartrate, and metoprolol succinate. Then bisoprolol, then carvedilol is very good drug, I'm telling, because of this structure. This structure is called as carbazole structure. This carbazole structure is very good antioxidants. See, in the heart, in the congestive heart failure, oxygen to the heart is not properly pumping. So what happens? Free radicals are generated. Now, when free radicals, more destruction to the heart. So you can avoid that free radical generation by using vitamin E. But this drug itself is having antioxidant because of this carbazole. And this carvedilol, you can see it, the antioxidant property is 10 times greater than vitamin E. So it is very good beta blocker as well as it is antioxidant. So antioxidant is very good here, very important. Why? Because free radicals are reduced. So that is, now that's what I told you in the previous slide. Among all the three, carvedilol is more prescribed because two effects. And it is also having diuretic property. Diuretic property. So these are the drugs, various drugs used in congestive heart failure. And uses. Any doubt, please? Now, someone can answer number 1 question. Lydia. Lydia is absent. Naval. Lydia, tell me, how does diuretics help in, for the first question, you tell the answer. Please do sign. Lydia, if you are there, you told me you are there, answer the question.
It helps to maintain the blood volume.
Okay, next question. Very good. Next question, you can see it. There are some drugs called as osmotic diuretics. Osmotic diuretics are very powerful, but they should not be given. They should not be prescribed for congestive heart failure. The osmotic diuretics are, examples are, I didn't write here, mannitol, injection mannitol, glycerin. So these are the some of the drugs. These drugs should not be given. Why? because these drugs will increase urine output, at the same time they increase fluid accumulation. See, these drugs, mannitol and all those, they are not absorbed in the body. So they stay in the blood. They are not absorbed. When they stay in the blood, what happens is that the fluid will more accumulate in the body. That's why osmotic diuretics are not given. At the same concept, in pregnant women, please try to listen. This is very important. In pregnant women, what happens is that during pregnancy, fluid will start accumulating. So there is one tradition in India. Everyone brings sweets and give to pregnant women. What happens is that when you eat more sweets, what happens? The sugar will help in excreting out of urine. Will help in excreting out urine. They do some rituals and they give more sweet or ask her to take more sweets. And why? Because the sweets help in diuresis process. So here in congestive heart failure, these mannitol is nothing but sugar. Glycerol is a sugar. These drugs are given IV route. They are not absorbed, so they stay in the blood. They start accumulating, collecting the fluid, and worsens the congestive heart failure. So osmotic diuretic should not be given. So what is the osmotic diuretic example? Mannitol, injection glycerol, these. They're not absorbed. Then novel.
Yes.
Tell me third question answer.
We have Metoprolol
Very
as an
good.
example. And how it blocks, it inhibits activation of the cardiac beta-1 adrenergic receptors.
Okay, that's very good. Can you explain about the salt so that students can recollect again? What are the two salts and why, when you can prescribe? Same novel.
Yes, come again, sir.
Why do you mute yourself again? Metoprolol. Can you discuss about the metoprolol salts? Ish.
Yes.
Explain about the answer. Explain about the question.
So metoprolol salts, there are two types. There is metoprolol succinate and metoprolol tartrate. We usually prescribe succinate for patients who basically want to maintain a steady blood level over a long period of time. Say for succinate, we give single dose. So the reason is because it is long acting as opposed to tartrate, which is short acting. So you give double, so 2 times a day. So 2 divided doses because it is immediate release formulation.
Okay, good. Very good. Then last question. Who can answer last question? Rutendo.
Yes, sir.
Read the last question and answer it.
Okay. Carvedilol is cardioprotective. what is the other way it is useful in CHF? So Carvedilol, from what I understood, it is like a non-selective beta blocker. So it is capable of causing vasodilation, and when it causes vasodilation, that means it reduces the blood pressure, and by reducing the blood pressure, it has an impact on the cardiac output, and hence it increases the cardiac output. No, it decreases the cardiac output, and the structure responsible for the above activity is its ability to act on the beta-adrenergic blockers. So you say the carbazole, if I'm not mistaken.
So carbazole is having antioxidant activity. So oxygen cannot be supplied to all the body. So in heart failure, cardiac output is decreased. When cardiac output is decreased, oxygen levels are decreased. So free radicals are more generated even at heart and also in our body. So antioxidants are better drugs. Okay, very good. Thank you for responding. Bye. Take care. Any doubt you can ask. I'll be the last person to leave. If you have any doubt still, you can ask